म्हणे हा म्हणे हा काय घेता म्हणजे हा झालं ना झालं ना काढून ठेव आता कशाला इकडे तिकडे काय करत राहतो चालत आहे थोडं हे घे बाबा
Darshana madam, can you hear me? Darshana madam, can you hear me?
येस सर.
सर जॉईन झालेले आहेत. ललित महाजन सर आपले स्पीकर.
हो सर, हो सर. आता
12
पार्टिसिपंट्स आतच आहेत. थोडा वेळ थांबायचं का आणखी?
हो 12 वाजून 2 मिनिटांनी सुरू करा. ऍटलिस्ट आपलं जे ऑर्गनायझेशनचे इंट्रोडक्शन आणि सुरू करत
सुरू केलं तर चालेल?
12 वाजता.
हो हो सर. येस येस. शुअर शुअर.
सुभाष वाघ
Madam, you can start the session.
Yes, sir.
Am I audible?
Yes, sir. Yes, sir.
Dr. Mahajan? Yeah. I'm sharing the screen now. Screen.
Darshana madam, you are not audible.
Am I
Darshana
audible
madam,
now?
you are not audible.
Hello?
Yes, you are audible now. Yes, go on, please.
Yes, yes, sir.
Yes, you are audible.
Okay, sir. Okay. Namaskar and good afternoon to all respected faculties, our esteemed speaker, Dr. Lalit Mahajan sir, respected chairperson, Dr. Subhash Wage sir, and all the dear participants. On behalf of organizing committee of RVPGA, Dr. Subhash Wage sir as president and organizing secretary, then Dr. Avinash Radke sir as vice president, Dr. Santosh Chauhan as secretary, Dr. Vaishali Ganarkar as treasurer, and myself, Dr. Darshana Ubhade, the webinar coordinator from Tilak Ayurved Mahavidyalaya, Pune. I welcome you all for the 26th Naidaniki webinar series on neurology, September 2024, which is organized by RVPGA and approved by MCIM Mumbai and Nagpur University. Last month we had the webinar series on gastrology, and throughout this
Your
month,
voice is breaking, madam.
Is it audible, sir? So we have a knowledge feast on different topics on neurology this month. Today we are here for the very first lecture of webinar series on neurology. As we know, in Ayurveda, the Vata dosha has an immense importance in terms of swasthya as well as disease condition, Vata Vyadhi and Majjava Srotodushti Janya Vyadhi, which corresponds to the neurological system and its diseases. Today's lecture is on the basics of nerve conduction study, and for that, we have among us our esteemed guest speaker, Dr. Lalit Mahajan sir. Before that, I'll request Dr. Bhagyadas sir from Government Ayurved College, Bolangir, Odisha, to give a brief introduction about our organization, RVPGA. Dr.
Thank you,
Das sir.
ma'am.
Darshana madam, your voice is breaking a lot. Can you please start?
Can you hear me? Hello, sir. Hello.
Yes,
Hello.
I can hear you.
Hello.
Namaste to all, respected all the dignitaries and our today's speaker. Now, I'm just summarizing all the activities which are going through the respected with the leading personalities of our respected Professor Subhash Wage sir. Some activities are I'm summarizing. First, we are doing the regular conduction of online webinars and offline seminars, both on national and international platform. So far, now we conducted almost 33 national webinars on different diagnostic topics. And this is our 36th academic activity. Secondly, we have conducted a national conference on X-ray diagnosis at Nagpur. Our second national conference on CT scan diagnosis is scheduled on coming 20th October 2024 at Nagpur. Hands-on training program for PG scholars at our partner NAVL accredited pathology laboratory at Mumbai, Nagpur and Pune and other cities of Maharashtra is going on. We have conducted a microbiological hands-on training program for our PGs on 9th March 2024 at Nagpur, and we will be conducting the workshop on molecular pathology techniques on 19th October 2024 at Nagpur. Our different publications are going on also with the publication of research papers of Nidan students and faculties in our peer-reviewed International Journal of Diagnostics and Research, which is summarized as IJDR. Who wants to visit, they can visit our journal with the website www.ijdrindia.com. Our journals is enlisted in 8 databases. 2 issues have been published. Also, the coming issues is ready to be published. We have edited book volume series through our international publication RIPI, which is registered in Government of India's ISBN portal. Those who want to contribute book chapters can visit our RIPI websites with the site www.rbpgaIip.com. We have published All India Rognidhan PG thesis book consisting of all the Rognidhan PG titles from the year 1985 to 2023 for the easy reference of our PG scholars and faculties. This year, we are publishing the All India Rognidhan PhD thesis book also. We are making legal fight for the issues of Rognidhan and Vikriti Vigyan PG's appropriate forums. We have our YouTube channel and a Facebook page where one can see our educational activities. Besides this, a lot of work is going on. Also, we have through the leadership of our respected Subhash Wage sir and also Chavan sir, and also a number of our executive members are there who are trying hard and hard, and one can be very much astonished that Subhash Wage sir working for 20 hours a day for the development of our Rognidhanians, also other faculties of Ayurveda fraternity throughout India. His excellence and his hard work will make the future of all Nidanians very, very delightful. And this is our almost the concise works from today. Thank you. Thank you all.
Am I audible, sir?
Yes, yes.
Okay, now I would like to introduce our today's esteemed guest speaker, Dr. Lalit Mahajan, sir. Dr. Mahajan, sir, has completed his MBBS from Government Medical College, Nagpur, Maharashtra, MD in General Medicine from Indira Gandhi Medical College, Nagpur, Maharashtra, and DM in Neurology from King George Medical University, Lucknow, from UP. He has many publications on his names. Sir is working since May 2009, and currently he is working as senior consultant neurologist in Max Alexis Hospital, Mankapur, Nagpur, since November 2022. Dr. Mahajan sir has good clinical experience in neurology in diagnosis and management of various neurological disorders like strokes, infections, epilepsy, and neurodegenerative conditions. Is well versed with the nerve conduction studies, electromyography, and electroencephalography, and visually evoked potentials. Is acquired skills in Botox treatment of movement disorders. Is a good first-hand experience with neuroimaging. He has gained sufficient experience in taking responsible decisions for the efficient management of the patients and is well versed with the managing critical patients in ICU. I welcome you, sir, again, and I request you to start the session. Over to you, sir. Dr. Mahajan, sir. So you can start the session.
Hello, am I audible?
Yes, sir.
Okay, I'm now starting the screen sharing. Windows Printer screen. Am I audible now?
Yes, sir, you are. Yes, sir, you're audible.
Yeah, yeah. I am starting now. Okay, I am
Sure, sure.
sharing the screen now. Yeah. Are the slides visible?
Yes, sir.
Slides visible?
Yes, sir. You can maximize
Slides
it.
are visible now, na? Hello?
Yes, sir, it's visible.
Okay, yeah, yeah. I'm starting. Okay. First of all, thank you, Dr. Mahajan sir, for giving me opportunity to present this seminar. So today's topic is the basics of now conduction studies. So I will cover this topic under the following headings. First, the introduction to the now conduction study. Second is the equipment and apparatus. Third is the recording technique of now conduction study. Fourth is the types of now conduction study, that is the motor now conduction study, sensory now conduction study, and what other factors that affect the now conduction study, and important basic patterns. Is that okay? Hello?
Yes, sir.
Yeah, yeah. Okay. So first of all, coming to introduction. So what is the now conduction study? So now conduction study is the recording and the analysis of the electric waveforms of the biological origin that are elicited in the response to electrical stimuli. It involves the recording, display, measurement, and the interpretation of action potential. That are the waveforms that are generated from the peripheral nerves. Basically, the our central nervous system or peripheral nervous system, they transmit the impulses in the form of the action potential. So now conduction study records this action potential and displays it on the monitor. So one should know the number of technical and instrumental related variables that can influence these action potentials. So what are the components of this now conduction study machine? So basic component used for the study are the electrodes. So basic requirement is the electrodes, then stimulator, now stimulator, amplifier, filters, and video monitor. So this is the diagram that is showing the electrodes G1 and G2. These are the electrodes. One is the active electrode, D2 is a reference electrode, and third electrode is there, which is a ground. And after recording the impulses, it get amplified and then filtered. Then the analog to display conversion it occurs. Digital analog actually occurs, which convert this biological potential into the waveforms. And after the processing, it get displayed on the video monitor. So coming to the electrodes, so where there are the three types of electrode actually. First is the active electrode, reference electrode, and third is a ground electrode. So there are the different shapes of these electrodes: cup electrode, disc electrode, ring electrode. Cup electrodes are usually used in the EG, and the ring electrode they are mainly used for the sensory nerve potentials. Hello,
नाही नाही ते 2-3
material.
सिलेबसचे जे आहेत पॉइंट्स तिथे
Can
I
you
request participant to
mute?
to mute themselves, please.
Yeah. My slides are visible, no?
Yes,
Hello?
sir. Slides are visible.
Yeah. So material, these are electrodes are usually made of the stainless steel or the platinum or the silver chloride material. So the silver chloride is the best. They usually give the less impedance. So placement, the before placing the electrodes, one should clean the skin with the alcohol or the acetone. Then place the electrode with the help of the electrode paste, and the inter-electrode distance should be maintained between the 3 to 4 centimeters, so that you get the least impedance. Coming to the stimulator, the second part is the stimulator. First is the electrode, then second is the stimulator. So the surface stimulating electrodes are the two metal or the felt pad electrode that are placed the 1.5 to 3 centimeters apart. They generate a square wave pulse in the milliamperes that depolarize the now under the cathode and hyperpolarize under the anode. So these are the two electrodes, and first one is the cathode and second one is the anode. So cathode usually depolarizes now, and anode is for the hyperpolarization. Hyperpolation occurs under the anode and depolation occurs under the cathode. So that is basically this depolation required for the generation of action potential. So what work the stimulator does, with the help of the stimulator, you can adjust the intensity of stimulus, means intensity of current, and duration of the current can also be adjusted with the help of the stimulator. So this is the basic stimulator. Other stimulators are also available that can easily on hand. Actually, they can adjust the current and the duration. Then the next is the amplifier and averager. So, what is the amplifier? Since the biological signals are very small, they are very small. These action potential are usually in the millivolt or microvolt. So, the variable degree of amplification, that is usually up to 5 lakhs times, is needed before being. So, this amplifier, it amplifies this biological potential and displays it on the monitor. And another component is the averager. So during the recording the now conduction study, we get a large amount of the electric noise. So this averager, it cancels out this large noise, and it leaves the only the signals of interest. The third part is a filter. So what the filter do, they selectively restrict the frequency domain of the signal. Only the selected frequency will be transmitted, and other frequencies will be filtered out. So it is required for eliminating the noise and optimizing the signal, thus bringing out the characteristics of the waveform. So the specific settings are used for the motor conduction study and the sensory conduction study. So for the motor recording, the lower frequency filter should be placed at the 5 hertz, and the high frequency filter should be placed at the 10 kilohertz. So if you why these are required, if you if you lower the lower frequency filter, then lower frequencies also will be transmitted, and it will hamper the, actually the baseline will be hampered if you allow the frequencies below the 5 hertz in case of motor conduction study. And high frequency filters are usually set at about the 10 kilohertz. And for the sensory settings, the low frequency filters are set at about 20 hertz, and the high frequency filter is set as about 3000 hertz, means 3 kilohertz. So these are the specific frequencies that are required for the proper display of the waveforms. This is the display screen. These are the video monitor, and other two figures are showing the these are the ports actually. So what the electrodes that we record, they directly, these are connected to these ports. And with the help of this also, you can adjust the stimulus intensity, body study. The patient should shower or bath in the morning of the test. Shower bath should be done. Avoid the.
Sir, your slide is not visible.
Okay. Is it visible now? Hello?
Yes, sir. Now it's visible. Yes, yes.
Is it visible?
Yes,
So,
sir.
the instruction to the patient. One should give the instruction to the patient. Proper instruction should be given to the patient on the day of the test. That is to take the proper bath morning of the test and avoid to the body. And one should wear the loose fitting clothes. And uh, in the lab, in the now conduction lab, one should maintain the temperature around the 33 to 34 degrees Celsius. Ask the patient to relax, clean the skin with the alcohol where you are to apply the electrode. One should clean that area properly with the alcohol or the acetone at the site. So all these are done. All this is done because to reduce the artifacts and to reduce the electrical noise. So what basic nerves we usually record in case of the routine nerve conduction study in upper limb. uh, Two types of conduction studies are there, motor conduction studies and the sensory conduction study. For sensory nerve conduction study, we routinely do the median nerve conduction study, ulnar nerve conduction study, and radial nerve conduction. And in the lower limb, we are doing the sural nerve conduction and a superficial peroneal nerve study. In case of the motor, median, ulnar nerve, and radial nerve in the upper limb, the peroneal nerve and the tibial nerve in the lower limb. So the first is a motor conduction study. So conduction study, they are performed by the electrical stimulation of the nerve and recording the compound muscle action potential from the electrode that is overlying the muscle supplied by nerve. So this is the motor conduction study. They basically record the compound muscle action potential. It is it is a summation of all the muscle fiber action potential. They are summated and it is called as a compound muscle action potential. So usually the belly tendon montage is used for the motor conduction study. Belly tendon montage means the active electrode. This G1 is an active electrode and it is placed usually in the center, over the center of the belly of the muscle. And G2 means it is a reference electrode. It is placed over the tendon of the muscles. And the third is a ground electrode. Ground electrode is usually placed between the stimulator and the electrodes. So this is the basic placement of the electrodes for the nerve conduction study, motor nerve conduction study. So current usually is set at 20 to 50 milliamperes, and the filters I already told. Lower frequency filter is set at 5 hertz, and the high frequency filter is set at 10 kilohertz. Sensitivity usually set at 2 to 5 millivolt per division, and the sweep speed usually at the 2 to 5 millisecond per division. And for conducting the motor conduction study, supramaximal stimulation is used. Supramaximal means you have to slowly increase the intensity of current, and when the point is this amplitude of the compound muscle action potential no longer it increases. So it is a supramaximal stimulation. You have to start by low current and gradually you have to increase that current so that the amplitude once becomes stable. Means after applying the current, that amplitude will not increase further. It is a supramaximum stimulation. So what parameters are used in these are the parameters that are basically you have to note down during the motor condition. First is the latency. Latency means it is a time from the stimulus to the initial compound motor action potential deflection from the baseline. This is the stimulus and this is the starting of the CMAP. So time, it is a basically the latency is the time it takes for the stimulus to travel from the stimulation site to the neuromuscular junction, as well as the time it takes for the stimulus to cross across the neuromuscular junction, and it is a depolar time across the muscle. So these are the three component of the latency. Means latency occurs because of these three factors. First is the stimulus to neuromuscular junction, then the time delay across the neuromuscular junction, and the depolarization of muscle. The second is the amplitude. Amplitude is the summation of all the underlying individual muscle fiber action potential. As, the CMAP is compound muscle action potential. It is the summation of all the individual muscle fiber action potential. It is calculated from the first takeoff from the baseline to the peak of the curve. So it is an amplitude. The third one is the area. CMAP area is a computer generated. It is automatically generated by the computer. It is calculated from the baseline to the negative peak. So in this is the negative. First one, the deflection, it when it goes upwards, it is a negative deflection, and when it goes down below the baseline, it is a positive deflection. Okay. So next is the duration. Duration is calculated from the baseline takeoff to the first baseline cross. Okay. And the conduction velocity. So these are the basic. Conduction velocity is calculated. It is actually the speed of the fastest conducting motor axon. Conduction velocity. It is calculated by noting the distance between the. Actually, in motor conduction study, you have to apply the two stimulus. First is the distance stimulus, and the second is the proximality will be calculated by noting the dividing the distance between the proximal stimulus and the distant stimulus, and is divided by the difference between the two latencies. Two latencies means distal latency and the proximal latency. When you divide this distance difference in the latency, then you will get the conduction velocity. Okay, so these are basic parameters you have to note down in case of the motor conduction studies. That is a latency. Latency means time it takes from the stimulus to travel to the electrode. Then second is the amplitude. Amplitude, it is a summation of all the muscle action potentials. Then the area is computer generated. Duration of action potential, compound action potential. Then the next conduction velocity. This is the sensory conduction study. So sensory conduction potential, these are very small potentials. So you have to you have to, use all the electric noise or the impedance during the recording. These are actually sensitive studies. These are sensory conduction studies. You have to record it properly. So while recording the sensory conduction study, the stimulus current is microvolt per speed, usually say 1 to 5 microsecond per division.
Sir, again, slides are not visible. Hello, Dr. Mahajan, sir.
I think the network is unstable. Even I too facing a lot of problem today.
Dr. Mahajan, sir, can you hear? The slides are not visible, sir.
चालू आहे actually. कुठे दिसेल कुठे? अच्छा, ते तिकडे. हा, ओके, तिथे एक जण. ठीक, ओके. हॅलो हॅलो, हा नेटवर्क ना, मी एक बस 2 मिनिटात जॉईन करतो. हा हा, ओके.
I just talked to the sir. He had lost the network and he will be joining within 2 minutes. Please bear with us. Ubari madam, can you hear me?
Yes, sir. Yes, sir.
Okay.
Hello, sir.
Yes, madam. Sir will be joining within 2 minutes. He had lost the network.
Yes, yes,
He's
yes, sir.
from another network.
Am I audible now? Hello?
Yes, sir. Yes, sir.
And my slides are visible now?
Yes, yes, sir.
Okay. Yeah. So where I lost, I don't know. Can you point me out where I lost the connection? Which slide?
The previous one,
Motor conduction study?
motor conduction.
Yeah.
Here? Okay. So the first part of the nerve conduction study is the motor nerve conduction study. Motor nerve conduction study, it records the compound muscle action potential from the surface electrode that are overlying the muscle that is supplied by that nerve. So for the motor nerve conduction study, the belly tendon montage is used. Belly tendon montage means there are two electrodes. First active electrode and second is the reference electrode. So active, that is a G1 electrode, is placed over the belly of the muscle, center of the muscle, and the second is the reference electrode, that is a G2, that is placed over the tendon of the muscle. That is actually tendon is electrically neutral. Hence, it is placed, G2 is placed over the tendon, and first one, that is active electrode, is placed over the belly of the muscle. And for that, the stimulating current is set given in between the 20 milliampere to 50 milliampere, and the filter settings are low frequency filter is set at the 5 hertz, and the high frequency filter is set at the 10 kilohertz. Sensitivity is set at 2 to 5 milliwatt per division, and the sweep speed around the 2 to 5 millisecond per division. And for that, the supramaximal stimulation. Supramaximal stimulation means the intensity of current is gradually increased, starting from low current to it is gradually increased till the till the amplitude of the current means it till this amplitude doesn't increase further. Okay, so starting with the low current, and it is gradually increased till the amplitude doesn't increase further. So it is the supramaximal stimulation is used. The basic parameters that are used are the noted in this motor nerve condition are the latency, amplitude, area, duration, and the conduction velocity. So the latency, it is the time taken for the stimulus to travel to the recording electrodes. So basically, the three sites are there which are responsible for the latency. That is the uh, stimulus site. Means latency is calculated. Actually, it occurs from the stimulus side to the recording electrode due to three reasons. First is for the time it takes for the stimulus to travel to the neuromuscular junction. Then from the time delay across the neuromuscular junction, and the time for the depolarizer. These three factors are responsible for the latency of the nerve conduction studies. And second is the amplitude. Amplitude is the selection of all the underlying individual muscle fiberization potential. Amplitude, which is calculated from the baseline takeoff to the peak. Okay. And next is the area. Area is computer generated. It is calculated from the baseline to the negative peak. Uh, Next is the duration. It is calculated for the first baseline takeoff to the baseline crossing. This one. Okay. And
Urea create sodium potassium
and next is the conduction velocity. Conduction
आणि
velocity is the speed of the
lipid
fastest
provide
conducting motor
cholesterol
electron.
TG आणि
Conduction velocity, basically it is calculated by dividing the distance between the proximal stimulation and the distal stimulation. For the motor conduction study, we usually use the two sides of stimulation. First is the distal side, and the second is the proximal side. So conduction velocity is calculated by dividing this distance between the two stimulators by the difference between the proximal latency and the distal latency. So when you divide this distance by the difference in the latency, you will get the conduction velocity. So these are the basic parameters you have to note down in case of the motor nerve condition. That is the latency, amplitude, area, duration, and the conduction velocity. Next is the sensory conduction studies. So sensory conduction studies, these are usually in the millivolt, microvolts. So these are the sensitive study. You have to cut down the noise to the very minimum level. So while stimulating the sensory nerves, you have to start by the very low amplitude current. That is it requires a very low amplitude current, 5 to 30 milliampere. The sensitivity is set at the 10 to 20 microvolt per division, and the sweep speed around the 1 to 5 microsecond per division. And the filter setting is a low frequency filter is set at 10 hertz and a high frequency around the 2 kilohertz. And for the sensory nerve conduction study also we use the supramaximal stimulation. So this is the diagram that is showing the sensory nerve conduction study of the median nerve. For median nerve, you have to place the active electrode around the base of the index finger, and recording that is a reference electrode, that is G2, up to the terminal phalanx, on the terminal phalanx, and stimulation is done over the wrist. So these are also the basic parameters of the sensory nerve, that is the latency, amplitude, duration, and the conduction velocities. So what is the difference between the CMAP and the SNAP? CMAP is the compound motor action potential, and the SNAP means sensory nerve action potential. These are the basically the compound motor action potential. It is a large amplitude potential. As you see in the figure, CMAP is a basically it is a larger amplitude, and the SNAP is a basically shorter amplitude, and the duration of the SNAP is means sensory action potential duration is shorter than the motor nerve action potential. So these are the two basic difference between the compound motor action potential and the sensory nerve action potential. Basically means amplitude is a larger in case of the motor action potential and smaller in case of the sensory nerve action potential, and duration is also the longer in the compound motor action potential and shorter for the sensory nerve action potential. These are the values, means normal values for the latency, amplitude, and the velocity of the various nerves. The common nerve we tested in the routine nerve condition, that is a median, ulnar, radial, and peroneal and the tibial nerves in the lower limbs. And sensory, we usually do the median nerve, ulnar nerve in the upper limbs, radial nerve in the upper limbs, and the sutular nerve in the lower limbs. These are the basic normal values for the compound muscle action potential and the sensory nerve action potential. So one should know what the factors can affect the this nerve conduction study. So basically they are divided into two factors. First is the physiological factors, means the temperature, age, height, proximal stimulation versus the distal nerve segment, and anomalous innervation. So these are the dependent on the means patients. So you have to keep this within the limit while recording the nerve conduction studies. And the other are the non-physiological factors. That is the electrode impedance mismatch, 60 Hz interference, filter setting, electron averaging, stimulus artifact, cathode position, supramaximal stimulation, co-stimulation, electrode placement for the motor study, antidomic versus orthodomic recording, distance between the electrodes and now distance between the active and reference electrode, limb position, sweep speed, duty, and sensitivity. So these are all the non-physiological factors. They can also affect the nerve conduction studies. So we will go one by one. First is the effect of the temperature. So what is the effect of the temperature on the nerve conduction study? So if the conduction velocity in conduction velocity slows by around 1.5 to 2.5 meter per second for every 1 degree drop in the temperature at the normal physiological temperature rate. That is the normal physiological temperature is the 21 to 34 degrees. If the temperature drops by 1 degree Celsius, then the conduction velocity slows by the 1.5 to 2.5 meter per second. If the temperature is down, then the distal latency also it get prolonged by about 0.2 millisecond per degree drop in the temperature, and the amplitude and the duration it increases. So you have to maintain the limb temperature at around the 33 to 34 degrees Celsius with the heating lamp. Means in the winter you have to take these precautions. So temperature of the limb should be maintained between the 32 to 34 degrees Celsius. Otherwise, you will get the wrong measurements. Means you will interpret it as wrongly as a conduction block or the neuropathy. Okay, so you have to maintain that temperature between the 33 to 34. Usually, it is made with the help of the lamp, and you also have to remember there's a time delay. It occurs between the hitting the skin and underlying nerve. So it usually delays about the 15 to 20 minutes. So after starting the hitting the skin, the underlying nerve, it usually takes the 15 to 20 minutes to get heated. Okay, to maintain that temperature. So it is the effect of temperature. Then next is the effect of age. The conduction velocity, half of the adult value. The conduction velocity is usually half of the adult value at the birth. Means in the full term infants. in 75% of the adult value. It at the age of 1 year it becomes the 75% of the adult value, and it reaches the adult range by about the 3 to 5 years. So the and it decreases with the age, especially greater than 60 years, by about 0.5 to 4 meter per second per decade. So conduction velocity, it also decreases as the age increases. It is occurs due to the loss of the motor and sensory neurons. So very low are the absent sural snaps in the elderly. It should be interpreted with the caution. So in the elderly, you can get the absent sensory nerve action potential in the lower limbs also, because it is a normal phenomenon. It is occurs due to the loss of the motor and sensory neurons. Next is the effect of height. So the taller individual usually have the slower conduction velocity. Conduction velocity slows in the lower limb than the upper limb. So why it occurs? Because the axons or the means nerves are they are usually longer in the lower extremities. So and they usually get tapered in the lower limb. So there occurs the decrease in the nerve diameter. So obviously, if the nerve diameter decreases, the nerve conduction velocity also get decreases. And second factor is the limbs are more pulled distally. So when you measure the conduction velocity in the lower limb and distally, they usually obviously they are the lower in the lower limbs than the upper limbs. And the proximal nerve segments, they usually conduct faster than the distal nerve segments. So if the patient is if the patient has got if the patient is very tall, then you have to adjust that conduction velocity according to the height. The next factor is the electrode impedance and the electrical noise. Most common you get the 60 hertz interference. It usually occurs because of the surrounding lights or the computers, fans, heaters. They usually create a problem, especially while recording the small muscle action, but small sensory nerve action potentials. So you have to look after this noise also. So how you will reduce this impedance of the noise? So the G1 and G2 means active and different electrode. They should be of the same type. Should be of the made of the same material, and you have to ensure that there is a no broken connection of the thread connection. You have to clean the skin with the alcohol. Means you should clean the recording area with the help of the alcohol and acetone. And one should apply the jelly paste between the electrode and the skin. And you have to secure the electrode with the help of the tape and the velcro. And ground electrode should be placed between the stimulator and the electrode. And always use the coaxial recording cables. Don't overlap the cables, so that you will get the less artifacts. So next is the filter setting. Low frequency noise that is less than 10 hertz usually result in the bending of the baseline. If you allow this low frequency noise less than 10 hertz, then there will be the bending of the baseline. High frequency noise greater than 10 kilohertz usually obscure the high frequency potential. High frequency potentials are the sensory nerve action potential and the fibrillation potential. If you increase the high frequency noise, then obviously they will obscure these sensory nerve action potentials. So these are the basic settings of the filter for the sensory conduction and the motor conduction. If you high frequency filter is lower in the sensory nerve conduction to reduce the this we have seen. And if the low frequency filter is reduced, more low frequency signal will pass through and the duration will increase. If the high frequency filter is reduced, the amplitude obviously it will get reduced. So the all the potentials should be recorded in the standard filter setting only. So this is the diagram. You can see here as the means as the high frequency filter increases, the amplitude it increases, but there is an increase in the electrical noise also. So baseline get disturbed if you increase this high frequency filter. The next is the electronic averaging. The electric noise may contaminate the potential despite filtering, especially while recording the microvolt range small potential, typically sensory nerve action potential and the mixed nerve conduction studies. So with the help of this electronic averaging, the serial stimulation get digitalized and mathematically they get average, because the electric noise is a random. So the positive and negative phases of the noise, they usually cancel each other and leaving the potential of interest. With this electronic averaging is used to reduce the electronic noise. So this is also the important setting. Next is the stimulus artifact. Stimulus artifact means when you give the stimulus, it creates a artifact also in the now condition study. So it is when it is problematic. It is problematic if the trailing edge of the stimulus is it overlaps with the potential being recorded, especially while recording the sensory action potential. It can obscure the onset of the potential, and it can lead to the inaccurate measurement of the latency and amplitude. So the large negative stimulus artifact, it can cause the low amplitude and the prolongation of the distance latency. And the large positive stimulus that can cause the increase in the amplitude and a decrease in the latency. So how you will avoid this stimulus artifact? You have to place the ground between the stimulator and the recording electrode. Ground should be placed between the stimulator and the recording electrode. You have to reduce the impedance mismatch between the recording electrode. Use the coaxial cables or avoid the overlapping of the cables. Ensure the stimulator position is stimulator is directly placed over the knob. Then give the lower stimulus intensity and increase to the supramaxillary gradually. You have to increase that, and you can rotate the anode while maintaining the cathode. That will place the proper position of the stimulator. It will place the stimulator in the proper position. And you can, if still the noise is there, you can increase the distance between the stimulator and the recording electrodes. So these are the various methods where you can reduce the stimulus artifact. This is the figure that is showing the first one means at the top you can see the stimulus artifact is very large. So it is a very large negative wave stimulus artifact. So it obviously it can decrease the amplitude of the sensory nerve action potential. And at the bottom you can see the large positive stimulus artifact. So obviously it increases the amplitude of the amplitude of the sensory nerve action potential. So you have to give the you have to look for this stimulus artifact also while recording the potentials. So next is the cathode position, reversing the stimulator polarity. So basically, while recording the now condition only, cathode is placed close to the active electrode, and the anode is positioned away from the recording electrode, active electrode. If the cathode and the anode of the stimulator are inadvertently reversed, two effects can occur. First is the error in measuring the latency. That is, the desired latency get prolonged by the 0.3 to 0.4 milliseconds, and the sensory nerve conduction velocity it usually decreases by the 10 meter per second, while the motor nerve conduction it gets unaffected. Okay, so this is the so when you reverse the position of the cathode and anode, so it can cause the increase in the latency and decrease in the conduction velocity. So you have to always keep the cathode close to the recording electrode. So other effect it can cause is the anodal block. Basically, if you keep the anode close to the recording electrode, obviously hyperpolarization will occur under the anode and depolarization under the cathode. So if the first depolarization occurred and if it spreads towards the anode, it will cause the anodal block, and obviously it will decrease the amplitude of the potential. So you have to remain very careful while positioning this anode and cathode during the recording. The next is the supramaximum stimulation. It ensures that all the axons are depolarized. If it is not the supramaximum stimulation, false impression of the axonal loss can occur. If the supramaximum stimulation not achieved at the proximal side, false impression of the conduction back can also, and it can lead to the false measurement of the conduction velocity. I think I have discussed the supramaximum stimulation. You have to increase the current gradually till the amplitude is reached, where the further increase in the intensity of current will not increase the amplitude of the potential. So it is a supramaximum stimulation. So next factor for error is the co-stimulation of the adjacent nerves. It often occurs when the stimulus is given above the 50 milliampere current. It causes spuriously high amplitudes. It obscures the low amplitude due to the axonal loss, and it can mimic the conduction block also. When you give the very high amplitude current, it can if you are recording the median now and you are giving a very high current, and then it can cause the stimulation of the adjacent ulnar nerve also. And obviously, if both the nerves are stimulated simultaneously, then it can increase the amplitude of the potential. So it can give the false impression of the axonal loss, and it can also mimic the conduction block. So you have to, hence you have to go gradually. That is, you have to go towards the supramaximum stimulation. So how you can avoid the co-stimulation? First, ensure the stimulator position is placed directly over the nerve. Stimulation should be placed directly over the nerve. Avoid the excess of the stimulation current. So you have to gradually increase the current intensity. Watch for the abrupt change in the wave morphology. If the wave morphology changes abruptly, means other nerves are also getting stimulated. Then the watch for the change in the muscle twitch. Obviously, if your other nerves are activating, then other muscles also get the twitch. So you have to look for the twitch of the other muscles also. Co-record the muscle simultaneously for the adjacent nerves. You can record that other stimulating muscles also simultaneously. So you can be sure of whether the other nerves are also getting activated or not. Always consider the possibility of distal combination when there is a conduction block is seen. When you are not suspecting the conduction block and you are getting the conduction block, then always suspect the distal co-stimulation of the nerves. Okay. The next factor is the electrode placement for the motor study. So you have to place this electrode at the proper position also. Means G1 is the active electrode. You have to place the active electrode at the center of the muscle belly, and G2 is a reference electrode. It is a means it is for the G2 is actually for the comparison of G1. So G1 is actually it is a electrically neutral. So G2 is placed over the distal muscle tendon. That is a belly tendon montage is used. And if the G1 is not placed over the motor point, if it is not placed a property over the center of the belly of the muscle, you have to record, then the depolarization begins at a distance from it and it travels beneath it, resulting in the initial positive deflections. If you place the G1 distally over the muscle, then obviously the depolarization reaches after some time and it will create the positive deflection. Hence, it will decrease the amplitude, and the latency is also difficult to measure if you get the initial positive deflection. So you have to place the electrodes at the proper position while recording the potentials. The next factor is the antidomic conduction versus the orthodomic recording. For the sensory recording, both the antidomic and the orthodomic recordings can be used. Means uh, the antidomic means the electrodes, they are placed directly over the nerves. In orthodomic, the electrodes are placed over the nerves and the stimulation is given distally. So for sensor recording, both these methods can be used, but there are the advantages and disadvantages of the both the methods. The distal latency and the conduction velocity, these are the identical in both the methods, but the antidomic method has the advantage of giving the higher amplitude, but snap may be followed by the large volume conducted motor potential in case of the antidomic studies. In antidomic studies, you can have the proper waveform of the sensory nerve action potential, but because of the co-stimulation or the motor nerve stimulation, it can cause the volume conducted motor potential. That is usually this first top diagram you can see. The first is a like that spike is a sensory nerve action potential, and it is followed by the curve that is of the motor action potential. That is a motor action potential. First is a sensory, and second is a motor action potential. So it is an antidomic study. But in orthodomic study, you will not get the motor action potential. It will not be followed after the sensory conduction studies. But in what is the disadvantage of orthodomic study? It will give the low amplitude potential. Basically, the sensory nerve action potential itself are the low amplitude studies. So if you perform the orthodomic studies, it can give the false impression of absent sensory nerve action potential also. So we usually use the antidomic method for the recording the sensory nerve action potentials. Next factor is the distance between the recording electrode and the nerve. The amount of intervening tissue and the distance between the recording electrode and the nerve can markedly influence the amplitude of the recording potential. So obviously, if there is a larger tissue between the stimulator and the nerve, then obviously it will hamper the potentials. And if there is a less amount of tissue between the stimulator and the nerve, obviously it will give the greater amplitude. So this is the diagram that is showing the when the stimulator is placed directly over the nerve, it will give the larger amplitude. When it is stimulator is placed 1 centimeter lateral, it will give the decreased amplitude. So as such, the distance increases of the stimulator from the nerve, it will give the it will cause the decrease in the amplitude of the potential. Next is a distance between the recording electrode. That is the distance between the G1 and the D2. The potential in the nerve conduction study is obviously it is due to the difference in the electrical activity between the active electrode and the reference electrode. If these are placed too close, then the low amplitude potential can occur due to the cancellation effect. So the preferred distance between the G1 and D2 is usually 3 to 4 centimeters, which ensures that the depolation doesn't occur in the both the electrodes simultaneously. So this is the diagram that is showing the proper distance. The middle one is the proper distance between the active and the reference electrode. So if you decrease the distance between the active and reference electrode, obviously it will decrease the amplitude, because the depolation can occur simultaneously between the active and reference electrode. So basically these potential occurs, these are recorded because of the difference in the potential between the active and reference electrode. So if you decrease the distance between the, obviously amplitude will decrease. This is the limb position on the distance measurement. So conduction velocity is calculated by the distance the potential has to travel from the proximal side and the distal side, and it is divided by the difference in the latency between the proximal side and the distal side. So obviously if you have to measure the distance between the proximal separation and distal separation correctly, so it can the difference can occur when the nerves are slacked. Example, if the ulnar nerve, you have to measure the ulnar nerve, it is usually slack in the around the elbow region. If you extend the elbow, it will obviously cause the decrease in the distance recorded. And if you flex the elbow, it will cause the means that will be the proper position for measuring the distance for the ulnar nerve. So it should be limb should be properly placed in the position before recording the distance for the conduction velocity. Next is the sweep speed and sensitivity. As the sensitivity is increased, the latency it decreases, and as the sweep speed decreases, the latency increases. Sensitivity it means it is for the amplitude, and the sweep speed it is for the duration. So all the latency measurement should be done at the same sensitivity at the same sweep speed. So next factor it can affect who can affect the animal are the anomalous innervations. The anomalous innervations of the nerves means it can occur in the 15 to 30% of the patient in the upper limb, or the it can occur unilaterally or the bilaterally also. Most common is the Martin Gruber anastomosis in the upper extremity. It occurs due to the crossover of the median and ulnar motor fibers. Sensory nerve fibers are usually spared. It usually occurs in the mid forearm, either directly from the median nerve or its branches, that is the anterior interosseous nerve. Means the fiber from the median nerve will cross in between, and it will it will attach to the ulnar nerve. So it is a anomalous innervation. Crossed median nerve fibers run with the ulnar fibers to innervate any of the distal muscle that is supplied by ulnar nerve. That is the medial nerve will supply the muscles supplied by the ulnar nerve. That is the first dorsal interossea, abductor deformity, or the thinner muscle. It can supply any one of these. Hence, it can be responsible for it can be mistaken for the abnormal nerve conduction study or the technical abnormality. So one must know what are these anomalous innervations. So this is the diagram that is showing the Martin Gruber anastomosis. Means in this figure, first figure, the median nerve, some fibers from the median nerves they are passing to the ulnar nerves, and they are supplying this abductor DGT minimi muscles. So when you do the routine ulnar nerve conduction study, it can give the false impression of the pseudo conduction block between the waist and the elbow side. Okay, and this is the anomalous innervation, same anomalous innervation, but the muscle supplied the first dorsal interossea. So it can also cause the pseudo conduction block between the waist and the below elbow sides. So one must know the anomalous innervations. When you are now suspecting the conduction block and you are getting the conduction block, then you should check for this Martin Gruber anastomosis in the upper limb. So these are the various physiological and non-physiological factors that can affect the nerve conduction study. One should thoroughly try to decrease these factors that are technically affecting the nerve conduction study. Coming to the important basic patterns you can observe on the nerve conduction. First is the axonal loss. Axonal loss means in axonal loss, the conduction velocity and distance latencies are the preserved as the largest and the faster fibers are the preserved. But the axon loss pattern is seen earlier for the motor than the sensory after the nerve transition. Axon loss you can see after the nerve transition about 3 to 5 days later in case of the motor conduction studies, and 6 to 10 days later in case of the sensory conduction studies. So the what parameters get affected if you get the axon loss? Amplitude get decreased, then the nerve conduction study can remain normal or slightly decreased, but it never goes below the 75% of the lower limit of normal. Distal latency, usually they get remain normal or they get slightly prolonged, but never greater than 130% of the upper limit of normal. These are the characteristics finding when there is a axonal loss. The next is a demyelination. What causes demyelination? It causes the marked slowing of the conduction velocity. It usually the conduction velocity gets slowed by greater than 75% of the lower limit of normal. And there occurs a marked prolongation of distal latency, usually greater than 130% of the upper limit of normal. Amplitude can remain normal or it can decrease or it can cause the conduction block also. Conduction block means the if you there occurs the greater than 50% of the decrease in the amplitude between the proximal side and the distal side. When it occurs, it is called as a conduction block. It usually occurs due to the demyelination. Or nerve transaction can also cause the conduction block. Any motor, sensory, or the mixed conduction velocity less than 35 meter per second in the arm and the 30 meter per second in the legs is usually suggestive of demyelination. So when you get the decrease in the conduction velocity, suspect the demyelination. So what are the parameters you look for demyelination on the nerve conductivity? Is a slowing of conduction velocity and the prolongation of the distal latency, and in the demyelination you can get also the conduction block also. So conduction block is the more than 50% drop in the area and the amplitude between the distal and proximal stimulation site. And the next one is the temporal dispersion. Temporal dispersion means there is a increase in the CMAP duration. That is, it occurs more than 15% drop in the CMAP duration. When the increase occurs more than 50%, it is a temporal dispersion. It is also the means it what it indicates temporal dispersion. It indicates all the nerve fibers are not conducting at the same speed. Obviously, they conduct at a different speed, but there occurs the more slowing of the conducting fibers. So it causes the increase in the CMAP duration. When it goes beyond 15%, it is called as a temporal dispersion. So summarizing the utility of nerve conduction study, the electrodiagnosis studies, these are the usually supplement to, and they are not a replacement for the history and physical examination. So you should not directly rely on the electrodiagnosis findings, but you should correlate them with the history and the physical examination. The nerve conduction study are usually used for the confirming the clinical diagnosis and excluding the suspected disorders. They are usually more sensitive than the clinical examination. Means on the you will get a more idea on the nerve conduction studies, like the whether the neuropathies are the axonal neuropathy or demyelinating neuropathy. You can classify the various types of neuropathy, and you can localize the lesion also on the nerve conduction. Means whether it is a mononeuropathy, whether it's a polyneuropathy, or whether it's a mononeuritis multiplex, whether the lesion is the radicals, whether the lesion is in the anterior horn cells or in the peripheral nerves. You can localize the lesions on the findings of the nerve conduction study. And nerve conduction study, they are also used for defining the severity, defining the prognosis, and the temporal course of the disease. Okay, you can repeat the nerve conduction studies later on to look for the whether there is a improvement or not. So, and another advantage, you can identify the abnormal innervation also. So the good knowledge about the generation of action potential and the technical factors influencing them is essential for the proper conduction and the interpretation of the nerve conduction studies. Thank you.
Thank you so much, sir, for your valuable guidance. Sir has guided us about the motor and sensory nerve conduction study, the instrument and apparatus are required, what are the factors affecting the nerve conduction study, the orthodromic and enteromic study, different basic patterns like axon loss, demyelination, etc. I'm sure the participant must have benefited from your lecture. Thank you so much, sir, again. Now we will move towards
Thank
the
you.
expert chairperson, Dr. Subhash Wage sir's opinion. Dr. Subhash Wage sir is very well known person, especially in the field of pathology Rog Nidan. He is the president and organizing secretary of RVPGA and a great and hardworking mentor in this field. With this very short introduction, I invite you, Dr. Wage sir, for your comments on this session.
Thank you, Darshana madam. Uh, it was very knowledgeable feast by Dr. Lalit Mahajan sir. First of all, I would like to extend my deepest gratitude and thanks to Dr. Lalit Mahajan sir for sparing his valuable time with us. Sometime, some 1 year back, I met him in one CMA, and that time he spoke on epilepsy. And that time only I requested him to come to our platform once to share regarding this now conduction study. Why we choose these types of topics, because there is no one to guide us on these newer technologies, newer techniques, which are required not only for the diagnosis purpose, but for the research purpose also. There in Ayurveda, many in many hospitals, the patient they come under the diagnosis that they have met with the Vata rogas, neuropathies, different types of neuropathies, mononeuropathy, polyneuropathy, and various demyelinating diseases. In those conditions, not only for diagnosis purpose, but for the research purpose also in various research institutes, these types of investigations are needed. There are several applications of action potential phenomena, which we see in the form of ECG, EEG, EMG, and the nerve conduction study. So, and we must get ourselves acquainted and with these newer technologies. And sir had nicely elaborated about the investigation regarding what the precautionary measures we should take before carrying out this investigation. What are the compounding factors in the form of age of the patient, height of the patient, weight of the patient, and the artifacts that can be produced while noting the things, and the motor and the uh, uh, effect on demyelination, diagnosing the demyelination of the nerve. So thank you very much, sir, for adding to our knowledge. I hope definitely it had added, it had made us more wiser than before regarding the nerve conduction study, and it was one of the one untouched area which was needed to be touched by one competent person like you, a neurologist person. Thank you very much, sir. I thank from my heart for sharing your valuable views with us and sparing the time with us. Thank you very much, sir. And we would like to have you to enlighten us for one more, some few more topics in future also. Thank you very much. Over to you, Darshana.
Yes, thank you, Dr. Wage sir. If participants have any query, they can type in the chat box or they can directly ask Dr. Mahajan sir.
I think there are no queries. I could
Yes.
not see any in the chat box.
Yeah.
But one more thing, I would like to say that my connection was very much unstable in the starting, and I could not hear Darshana properly. So sorry from my side also.
No, sir.
Uh,
That's fine. So
We
if
can
there are,
move on to next.
yeah, yes. If there is no more any query, then we will move on the last part of the session, the vote of thanks. For that, we have Dr. Madhvi Gaikwad, the Associate Professor in the Department of Rog Nidan from Chhatrapati Shahu Maharaj Education Institute, Ayurved College, from Chhatrapati Sambhajinagar. So I request Dr. Madhvi Gaikwad ma'am to give the vote of thanks.
Am I audible, madam? Am I audible?
Yes, you're
Yes,
audible.
madam.
The volume is little less.
Good afternoon, everyone. On behalf of the organization, I would like to extend our deepest gratitude to our esteemed chief guest speaker, respected Dr. Lalit Mahajan, sir. Sir, your valuable insights have significantly contributed to the success of today's webinar. I also thanks to today's chairperson, Dr. Vivek Agrawal, sir. Thanks to coordinator, Dr. Darshana Obade. So heartfelt thanks to RVPK President, respected Dr. Subhash Wage, sir, who are always take a initiative for organizing such an informative and knowledgeable webinar. Thank you, sir, for your tireless efforts and meticulous planning. Thank you to RVPG Secretary, Dr. Santosh Chavan, sir. Thanks to RVPG Treasurer, Dr. Vaishali Ganorkar. Last but not least, a special thanks to audience for your active engagement and enthusiasm. Your presence and contribution made this event a collaborative success. Thank you. Over to the Ubale ma'am.
And many thanks to Darshana madam for nicely coordinating the event. I think, and there is one more suggestion to the audience that we are conducting a national conference on CT scan diagnosis on 20th October 24 on Sunday. So please join us there at Nagpur. And we are also conducting the X-ray workshop and the molecular pathology workshop on 19th October, Saturday at Nagpur, Amrut Bhavan. So please join us there at Nagpur. And I also request from next time that you please ask the audience to mute their mics because they produce unnecessary disturbance in the lecture. So this precaution we need to exercise. With this, I declare this session is over and one can leave the meeting.
Thank you, sir.
Thank you, sir.
Thank you,
Thank you.
everyone.